Progesterone. I hope you've had a very happy Sunday. I was going to focus more on progesterone intolerance, and I've had a huge, almost record number of questions from many people, so thanks for sending them. Progesterone is one of those hormones that is often neglected actually, because when we talk about menopause, perimenopause, it's usually about estrogen. It's usually about estrogen deficiency. It's usually about flushes and sweats. But actually, many of you know it's more than just estrogen. We've got other hormones as well. And progesterone is often, I think, a misunderstood and quite forgotten hormone. Many of you might know that our hormones, estrogen and testosterone, actually come from progesterone, and cortisol, our stress hormone, actually comes from progesterone as well. Chemically, they're very similar in structure. So progesterone is very important. It's a sort of building block of hormones. And when I talk about progesterone, I mean the natural progesterone that we produce as women, and men actually produce it too. So it's a hormone that's produced in our ovaries, it's produced in our adrenal glands, and very importantly, it's produced in our brains as well. So our brain makes progesterone. Every cell in our body has receptors for progesterone on it, which means that progesterone is needed for certain biological processes that occur in cells. So it's a hormone that we produce when we're younger. It actually is fluctuating when we're having our periods. So often the second half of the cycle after ovulation, we have a peak of progesterone and then it falls very quickly. If we don't become pregnant, the rapid decline in progesterone will trigger the lining of the womb to be shred and a period. And so many women actually find that they have symptoms related to changing progesterone levels. So it's not so much the progesterone, it's the changing levels that can trigger various symptoms. Now, many people, myself included, have been taught that we only need progesterone as part of HRT if we've still got our womb, and we have it in two different ways, either as cyclical, so 2 out of 4 weeks usually we have progesterone, which way, in that way we'd still have a period, although it's like a withdrawal period, it's not a natural period. Or we take the progesterone all the time, every day, and then it usually means that the lining of the womb is thin, so we don't have periods. So that's two ways of taking progesterone as our HRT. But, and there is a but here, it's not just about the womb. I've already said that we have progesterone that affects every cell in our body. So whether we have a womb or not, progesterone can still have an important role for many people. And so we shouldn't be thinking of progesterone as just for the womb. And I have done a YouTube, like an Instagram live that's on my YouTube, it's on my grid, all about progesterone and the benefits. So I'm not going to go through all that again, but it might be worth watching or listening to it if you haven't seen it before. We've got this very simple picture about the influence of progesterone, and it just really highlight the brain, the bones, the immune system, the breast metabolism, psychological well-being, muscles, as well as our reproductive sexual function. And it's called the influence of progesterone, and I'll put a link to it up on my story later tonight. But it's just really to highlight that progesterone affects every organ in our body, but especially our brain. So we can't really think of it as just for our womb. Now, as I've said at the beginning, progesterone is the natural progesterone, but a lot of people will call synthetic progesterones also progesterone, and it can cause no end of confusion for women, but also for healthcare practitioners as well. And for those of you that are coming on my tour, you'll hear a lot more about our hormones and the synthetic hormones and how different they are. But essentially, unless it's called progesterone, and it's usually the micronized progesterone or a progesterone pessary, which I'll talk about in a little bit, then it's usually synthetic. So even though it's called the progesterone only pill, it should really be the progestogen only pill, and a progestogen means a synthetic progesterone. So it's been chemically modified. It might only be a small modification, or it might be a bigger modification, but it means that it doesn't have the same lovely biological effects as natural progesterone does. It doesn't fit on the receptor in the same way, it doesn't have the same biological effects, so therefore it can have side effects. And certainly as a younger doctor, I was shown lots of tables with lists upon lists of all the different synthetic progestogens that are in contraception, that are in types of tablet HRT, and showing what sort of side effects they have, whether they affect the androgen receptors, whether they affect mineralocorticoid, which is like can cause more bloating, it can affect our kidney function, and ones that can affect skin as well. So many people, I'm sure some of you listening, will have had different types of contraception in the past and been limited by side effects such as acne or bloating or mood changes. And this can all be related to using synthetic progestogens, and they're all different and they have different side effects, but they're not the same as natural progesterone. So progesterones that are synthetic, that are in contraception, that are in the implant, that are in the Depo-Provera contraception, that are in combination forms of HRT, including tablet combinations other than Bijuva or Bijuva, which contains the natural progesterone. The combination patch for HRT, like something like Everol Conti or Everol Sequi in the UK, that contains a synthetic progestogen as well. So they are very, very different. And I'm labouring the point because many women I see in the clinic and the clinicians that work with me see as well, tell us, I can't have progesterone ever because I'm really intolerant from it. I tried the coil, or I tried the progesterone pill when I was younger and I felt dreadful, so I'm never having progesterone. But it's different because it's not synthetic. Now the coil, there's different types of coil that contain synthetic progestogen. The commonest one that many of people will have heard of is the Mirena coil. We've also got ones with lower doses. There's in the UK there's Kylena and J-Des. They have smaller amounts. Now these are very, very small, and they work in the womb, and they keep the lining of the womb thin, so people don't usually have bleeding on them. Now, they don't usually get into the system, but I have seen and spoken to a lot of women who have had a reaction, if you like, to using the intrauterine system, such as Mirena, because some of it will leach into the bloodstream. And if people are really sensitive, it can still trigger some side effects. And I know it's related because when women tell me, then they had the coil removed and they felt normal within a few days. So it's not all in their minds. And we have to be really mindful for some women who are very sensitive to the synthetic progestogens. And they could be labelled as having a progestogen intolerance, very different to progesterone, because it doesn't mean necessarily these women are going to be intolerant of the natural progesterone. So the synthetic progesterones, it's very important if you're speaking to a clinician, try and write down what you've had in the past and what sort of side effects you had. And the commonest side effects can be the ones I said. So bloating can be a problem, skin changes, mood changes especially can really be a problem with the synthetic progestogens. And I have had spoken to many people whose mood has absolutely plummeted when they've been on synthetic progestogens. And if those of you were on HRT in the cyclical form, so you're having 2 weeks of just estrogen, 2 weeks of estrogen and a synthetic progestogen, you'll soon know whether you have any problems or not. And a lot of women say, I was fine when I was on the estrogen only part. As soon as I took the combination patch or the other tablet, that's when I really plummeted and felt really unwell or really sad or very tearful or really out of sorts. And if that happens, then it is a sign that you are responding adversely to the synthetic progestogen, and it's definitely worth thinking about changing it. Whenever anyone starts HRT, it can sometimes take several weeks, even up to 3 months, to feel fully adjusted really to the hormones. But if you're getting a severe reaction, as in your mood is really low, you don't have to wait for 3 months. Come and talk to someone and we can talk about options available to you. Some people who have the Mirena coil find that after 3 months or so, mainly because the concentration lowers, is less in the bloodstream and the body, that actually any initial side effects do settle as well. Other side effects can include indigestion actually, and some people get skin rashes. Even hair thinning and hair loss can occur with the synthetic progestogens, and this is partly because they're blocking the natural progesterone working in the body, because they have a higher affinity for the progesterone receptor, as I've already said, is on every cell. So not only do they not have the same biological effect, they block the natural hormone. If anybody still has progesterone around, it's going to block it working, so be a double whammy. Some people take them and they're absolutely fine, but they can really make side effects for some people, meaning that a lot of people are scared of taking HRT because of these problems with synthetic progestogens. The other thing is there are actually some health risks with synthetic progestogens. We can't talk about hormones altogether, and this has been some of the problem over the last, decades really, when people have been scared away from HRT, because often when people talk, they talk about all hormones together. And as you know, the synthetic hormones are very different to the natural hormones, which are the same biological, biochemical structure of the hormones we produce when we're younger. So the synthetic progesterone, the progestogens, act very differently, and so therefore not only can they cause side effects, they can cause health risks as well. And when I say that, we have to be mindful that the studies that have shown a breast cancer risk have always been those containing synthetic progestogens. So they are usually medroxyprogesterone acetate, MPA, which was in the big study, the Women's Health Initiative study, but have been in other studies as well. And every so often there's a conversation about the contraceptive pill being associated with breast cancer. And it does seem it's only a small risk, but it's there in the same way as it possibly is there with some types of HRT that contain the synthetic progestogen. So there is the studies aren't great, don't know, it's very low, but this breast cancer risk, but it's with the synthetic progestogen. But the other risk that the synthetic progestogens are associated with, which is important I think for everybody to know, is a risk of clot and stroke, and also a small risk of heart disease as well. And that's very important when we're giving hormones to older women. We want women to be healthy. We want to reduce risk of heart disease and clot and stroke. So what we don't want to do as clinicians is to give women a type of progestogen that is going to increase their risk, especially if, for example, they've had a clot before, or they're a migraine sufferer, and we know that women who have migraines have a only small increased risk of stroke. Or if someone's had a stroke before, for example, we wouldn't be giving them synthetic progestogens, whatever age they are. But as we get older, our risk of clot, our risk of stroke, our risk of heart disease increases with increasing age. So it is important that if you're having a progesterone and you're older, you're on a HRT, first line really should be the natural progesterone, because you're less likely to get symptoms. But I think as a clinician, more importantly, you're not going to have the negativity towards future health risks. So you won't have an increased risk of heart disease, clot, stroke, breast cancer, if there is one, with hormones. That's not there with the natural progesterones. So it's really important when you're starting HRT, have all the information. You might decide that the risk is so low that you want to have a combination tablet which has a synthetic progesterone because you've taken synthetic hormones for ages on the contraception and you were fine with that. Absolutely not a problem. It's all about choice. I'm sure a lot of you realise the work that I'm doing is just about allowing people options based on knowledge, and the knowledge is the most important thing for us all to obtain. So synthetic progestogens are different to the natural progesterone. So then let's talk about the natural progesterone. How do we get it? Well, it's usually given as part of HRT, and traditionally it's for women who still have their womb, because if you have estrogen on its own, even the natural estrogen, it can build up the lining of the womb and cause something called hyperplasia, which basically means thickening of the lining of the womb, and that can cause bleeding. Now, there hasn't been any studies that show that increases risk of cancer of the lining of the womb. We know that the older types of HRT containing the pregnant horse's urine and synthetic hormones can increase, only small, risk of cancer of the lining of the womb. But bleeding is a real nuisance for women on HRT. You wouldn't give women estrogen on their own if they still had a womb. So we always offer a progesterone. And usually, like I say, it would be the natural progesterone. Two ways of having it. So the cyclical way, like I've said before, for 2 out of 4 weeks, or continual where it's taken every day. And we usually start that after 6 to 12 months of a woman not having periods. So if someone's perimenopausal and they've just had like the odd period over the last year, then I might start continuous HRT. Or if they're still having some irregular periods but they're happening quite frequently, then I'll often start women on the HRT, so it's 2 weeks of progesterone and 2 weeks off the estrogen all the time, and that way they'll get usually regular periods. And we continue that for 6 to 12 months, depending on the woman and the situation, and then change to a continuous, because most of us find the best thing of being menopausal is not having periods. Probably the only advantage, really. But again, there's no definitive time. I've read papers where people say it has to be after 2 years, or the woman has to be 51. Well, there's no scientific reason for that. It's really about individual choice, what your periods are doing, how quickly you want to go on to continuous HRT. When we give it cyclically for 2 out of 4 weeks, we give a higher dose, so it's usually 200 milligrams of oral progesterone, whereas when we give it continually, it's usually only 100 milligrams. And that is important to know, because some people again say, I feel dreadful when I have the progesterone, and then the 2 weeks where I'm just having the estrogen, I feel great. But then they're having a higher dose. So sometimes actually with women who still think they're progesterone intolerant, I'll change them to a continuous type, so they have the same progesterone but half the dose every day, and they feel better for 2 reasons. It's a lower dose, but also it's the same all the time. The body, like I said at the beginning of this presentation, the body doesn't like change. Think of that graph when just before our periods, the progesterone drops very quickly. So if you're having progesterone for 2 weeks and then stop taking it, it might be the change that you're not having it that triggers some side effects. So it's just important to think about that. Now, when we take the pure progesterone orally, it has to be anything that we put in our mouth goes through our liver. Our liver is like a sieve. It's an amazing organ, and it sieves out any badness. It actually it processes everything that we have as well. And so obviously we know that if we have toxins, if we have alcohol, then it will metabolize that, and to produce, it will break things down, so produce it so that it's easier for the body to absorb. Now, if you are having oral progesterone, again, it's going to be broken down in the liver, and it does get broken down to other types of progesterone as well. Now, sometimes that can be quite advantageous, because if you have it orally, it can affect something called GABA, which is a chemical in our brain that helps us relax and sleep. So we usually say the progesterone, the Utrogestan it's called usually in the UK, is taken at night time, because people often take it half an hour before they go to bed, and then they sleep really well because it's stimulating this GABA in the brain. But some people find that they can't tolerate it. They still get side effects. So despite using a lower dose every day, despite being on it for a few months, people sometimes say, but I still feel awful. I still feel tired. I feel really zombied. I feel low in my mood. I'm bloating. I really don't feel myself. And so what we try and do then is think about alternatives. So one of the things that is can be quite advantageous is, rather than having it orally, it can be used off licence vaginally. Now, we sometimes give the same capsule because the capsule can melt in the vagina. The progesterone gets absorbed through the vaginal mucosa. But the other thing we can do is use pessaries. So there are pure progesterone pessaries. They have been used for many years as part of fertility treatments. One that many people will have heard of is something called Cyclogest. And we can use that either vaginally or rectally, and it just gets absorbed through the mucous membranes into the bloodstream as the pure progesterone. So it doesn't get converted through the liver, it doesn't have the same side effects, and we can use different doses depending on the clinical scenario. Some studies have shown actually that it's better for the lining of the womb because it's being used closer, it doesn't get metabolized. So the oral dose is not always equivalent to the vaginal dose. And again, it depends on the individual. I know many of you have asked about the dose of estrogen compared to the dose of progesterone, and that's very individualised because it depends on how the estrogen is absorbed, depends on how the progesterone is absorbed or metabolised, depends on the symptoms of the woman. So I very strongly feel that it should be an individualised choice about the dose of estrogen compared to the dose of progesterone. But progesterone vaginally or rectally is just a personal preference really, where you want to put this pessary, can be used in different doses. Now sometimes, and I know this might sound a bit strange for some of you, but some women who think they're progesterone intolerant, they're intolerant of too low a dose. And so if they're only having, say, 100 milligrams orally, we might increase the dose vaginally to maybe 400 milligrams, do it gradually, and they might be using that 2, 3, 4 times a day. It doesn't last very long in the body, but sometimes people say, gosh, this higher dose, the pure progesterone that's absorbed through the pessary, has been transformational, and they usually can work that out quite quickly. So it can be worth trying, rather than saying, do you know what, I can never take progesterone again because I've had an awful experience. And increasingly we find, especially women who've had PMDD, they've had PMS maybe in the past, they've been intolerant of synthetic progestogens in a coil, in a contraception, they've not been able to take progesterone, the natural progesterone orally, having it as a higher dose as a pessary can make a really big difference actually. So it's important to try all options before saying absolutely not, I can't have progesterone. So if someone is still intolerant, but they've still got their womb, what do we do then? Because it's a bit of a dilemma, isn't it? The estrogen we know has benefits for symptoms and for future health, but it can thicken the lining of the womb, so we can't not give progesterone. There are different regimes, and sometimes we do use off license, obviously, a regime where people only have progesterone every 3 months. And there have been some types of HRT that only give progesterone every 3 months. So as long as someone has usually has a bleed afterwards, and then those women will usually do a scan every year to check the lining of the womb. And we usually do the scan after any bleed to make sure the lining of the womb is thin. So that is an option. Some women really struggle with any progesterone, especially when it's affecting their mental health. And there have been some women who have elected to have a hysterectomy because they want to continue with the estrogen, but they absolutely can't tolerate progesterone. But I've literally got a handful of women, and I have a huge number of patients who have elected to do that. And again, this is about being individualised, making sure you've explored the options, knowing what are the risks of a hysterectomy to what are the benefits of being on HRT long term. And so that's just something that sometimes people talk about. Now, the other thing is, if you've had a hysterectomy, does that mean you don't need progesterone? For some women, they don't want progesterone, but some women do. And you can be, as a clinician, we can be a bit more relaxed about the dose because they haven't got the lining of the womb that's going to get thickened. So if someone is on HRT and they say, do you know what, I just want to try maybe a low dose of progesterone, or maybe just try it every other day or twice a week, that's possible. And some people find that a lower dose, you still get benefits with having the progesterone. There is a progesterone cream that is, it's off-label, but we can prescribe it for some people. We wouldn't prescribe progesterone cream to protect the lining of the womb because there isn't enough evidence. It doesn't get very well absorbed through the skin. But some people find that it really helps their mood, mental health. They prefer it because it's a very low dose that's used and they are completely in control of it. Doesn't have to be metabolized because it rubs on the skin. And so for women maybe who've had a hysterectomy hysterectomy, or maybe women who have had a Mirena coil-in and they want to try the benefits of the pure progesterone. That is certainly an option, and I'm going to be doing a podcast about that quite soon with a psychiatrist I know who prescribes the progesterone cream, so you might find that helpful. Some people have asked about migraine and progesterone. It's very interesting. Some people find, especially if they have cyclical progesterone, it can trigger migraines, but we know anything that affects sort of routine can trigger migraine. Some people are better having it vaginally rather than orally, and using it continually, so using it all the time if they have migraine. But certainly it's not detrimental. It's really good in our brains. It's very neuroprotective. It works as a neurotransmitter. It helps reduce inflammation in the brain as well, and it helps repair the brain. So progesterone is a very good neurosteroid. It's a really good hormone in our brain. So many people do benefit from it. So it is worth thinking about progesterone, certainly if you've got symptoms as well. Some people have asked about endometriosis, and if they're finding that the estrogen is triggering their endometriosis, and I did speak about this last week. Sometimes we will just start off giving progesterone, or if someone's perimenopausal and we think they're more progesterone than estrogen deficient, we might give progesterone first just as a very low dose, either orally, vaginally. It really is very individual, but it can be given for people with endometriosis. And I worry when I speak to so many women who've got endometriosis who have basically been told to block all their hormones because their hormones are awful, and then they can feel worse too. And obviously there are health risks of not having hormones as well. So the other thing just to add is that there is another type of Protex that's available in the UK called Protex, which I'm not sure which manufacturer it is. I don't know if now I presume it's cheaper. I'm not really sure why it's come to market. I mean, it's good to have a choice, of course, but some women report that they feel worse using it, and I don't know whether it's absorbed more or less, or whether it's something in the ingredients that's different. I actually don't know, but there are some people who feel better on Progesterone than this new Protex. So just if you do notice that you're getting some side effects you didn't have before, just look at the packet and see what it's called. And rather than saying, I'm definitely progesterone intolerant, you might just be intolerant to that type of prescription, and it might be worth thinking about Progesterone or thinking about the Cyclogest Pessaries, the Pessaries of progesterone. Finally, just to add about postnatal depression, many of you know that our hormone levels are really high when we're pregnant, and they fall off a cliff when we have a baby. And the progesterone especially really does fall very quickly, and that can trigger mood symptoms. And so for some people, having progesterone postnatally can make a difference. And of course, it's very safe to try these things. Sadly, a lot of the perinatal psychiatrists don't think about hormones, but it is obvious, and they can still be given alongside any other treatment. We can't measure progesterone levels very easily in the blood because they vary so much. And often with a blood test of progesterone, it's not what it's in the blood, it's what's in the tissues and the brain. So usually it's more of a clinical diagnosis, progesterone deficiency or progesterone intolerance. So it's not a certain level of progesterone that we're working to or worried about if someone is having symptoms. And finally, the other thing to add is that when people are perimenopausal, they're often still, I see people who are having symptoms, but they're still having regular periods. So they're still producing progesterone. And sometimes those women, when we give them progesterone, it's like they're having a double dose and they feel worse. But then when their periods stop and they become menopausal, obviously their internal progesterone lowers. So then giving progesterone as a prescription, they feel fine because they're not having this double dose. So if you think you've not tolerated progesterone well, but you were perimenopausal and now you're a bit older, it might be worth re-exploring. So there's always options, and I'm hoping what you're all learning is that we're all different. The way we metabolize food is different. The way we feel after having doing anything, like even exercise or sleep, or I don't drink alcohol, but different people react differently to a glass of wine, and it's the same. Or different people have different side effects to medication. It's exactly the same with hormone doses. And some people find that they tolerate progesterone much better when they've got estrogen and testosterone on board as well, because these three hormones often need balancing as well. So don't give up. If you're struggling and you think you've got progesterone intolerance and you've been told just stop taking HRT, I would really think about seeing a specialist who understands the role of these three hormones, and thinks about the importance for your future health of having hormones as well. So hopefully that's been helpful. Lots of information, and I will put some links on my story a bit later tonight. But keep going. Think about your choice. There's always choices. There's always options. And anything that you do try, you've got to try and use it for several weeks before you know whether it's really helpful for you. So enjoy the rest of your Sunday, and hopefully see you next week.